Welcome back to Fuzzy Logic, the podcast that breaks down the incentives that guide the decisions we make to understand who benefits from the status quo and what's at stake for the future. I'm Matt Haller.
And I'm Chris Michaud.
On this week's show, we'll be diving into something that seemingly gets more and more expensive on the daily, healthcare. But why is it so expensive, and will the status quo ever be disrupted? When we look at the healthcare industry in America, the United States spends more per capita and overall than any other country in the world. And that isn't just limited to primary care. That is across the entire industry, from prescription drugs to health insurance, and it is by far heads and tails above other developed nations. So, Chris, can you help us understand a little bit more about how we got here and when healthcare costs really started to skyrocket?
Yeah. So back at the end of the 19th century, some employers started offering health insurance, but it was meant more as income protection back then. So it was more about giving you income if you were injured. In the 1940s, health insurance really was designed more for how we think about it today. And the reason this happened is the government encouraged it in two ways. First, Second World War froze wages. So health insurance had to be given as a benefit and it was tax exempt. So as an employee, you didn't pay it. And then in the 1950s, employers got the same treatment where it was a deductible expense from taxes. Both the employer and the employee benefited. And what that really meant is that modern insurance as we know it today came around. But even then, healthcare was still pretty low. It was only about 5% of the economy versus 20% today, which is insane. In the 1960s, then what happened was the introduction of Medicare and Medicaid, and that gave more people the opportunity to head to the doctor. And of course, they started using it. But the upside was life expectancy went up a lot. So in the first 20 years of Medicare, from 65 to 85, the average life expectancy went up like 25%, which if you think about that now, that would mean we'd be all over 100, which obviously isn't happening. However, the side effect of that is increased demand and meant increased prices. So throughout the 70s and 80s, prices rose on an average like 14%. And that was due to government regulation. And it kept rising through the 90s and the early 2000s. This put pressure on employers who once treated healthcare as a low cost benefit. So that led to things like coinsurance and copays. In addition to that, the prescription drug market exploded as well. So birth control came out in the 1960s. Modern antidepressants, as we know them now, came out in the 70s. You had statin medications like cholesterol in the 1980s, and then Viagra and ED drugs in the 90s and on. So the result of this has actually been the doubling and tripling of drug prices. Believe it or not, governments actually tried to contain this in a couple of ways. So first, in 2003, the introduction of the healthcare savings account. So the idea that you could treat healthcare savings as an investment like an IRA. But then also the Affordable Care Act, obviously in 2010, came out. And both of those things were tried to design to contain and control costs. But the reality is, since the introduction of those things, healthcare costs have essentially still doubled. So there doesn't seem to be any end in sight.
Well, what I think is a challenge for that pie getting bigger is that we need to find more places to fund it. There's more services that we're providing. And so when we look at the way that the government has tried to contain costs, have they actually tried to create an incentive to reduce those costs? Or is it really just, I'm creating more bank accounts, more pockets of funding where we can slap a Band-Aid on these rising costs across that ecosystem?
I think the problem is we spend a lot of money on healthcare and most people feel that it's not very good. So I think we need to think about, from an incentive perspective, where do we get our best bang for the buck on healthcare? I think some of our guests today will really hit on how we can incent people to take care of themselves and provide ways to do that, as opposed to catastrophic healthcare. I think it's something that probably weighs on cost pretty heavily. And from a rewards perspective, I think people feel like they're getting shafted.
We talked in our housing episode about an economy that was like a sweater size too small for the world that it's trying to inhabit. Is healthcare the same? That as we have dramatically expanded access in the 60s with Medicare and Medicaid, in 2010 with the Affordable Care Act, have we also kept pace with our providers and creating an appropriate set of access where it might be more cost effective for the patient and the provider in order to serve care? Or is it that we have such a shortage of medical professionals in this country that we are trying to artificially work around that issue by inflating costs and making those jobs more attractive?
I think our guest will hit on this as well. What's the incentive to become a doctor? And so specialization and ways that a doctor can actually earn a living versus general practitioner like you and I would think any average GP would make good money. The reality is they don't. They actually make very little money. And a lot of healthcare systems have bought up, again, an efficiency play, and kind of an unanticipated effect of the Affordable Care Act was saying, okay, you can't consolidate. You have to spend a certain amount of money on patient care. So what happened was the big insurance companies went out and bought pharmacy benefit providers, which wasn't part of that loophole. So the incentive for insurance companies and other organizations as part of the Affordable Care Act, there's been some unanticipated consequences. But back to your point around the economy and where it fits in the incentive, McKesson is one of the biggest companies on the planet, and all they do is provide medical equipment and consumables. We're not even talking about doctor care, right? We're talking about just purely the stuff to make it happen. So if you're on a Fortune 10 list for that, that tells you exactly where the incentives are in healthcare and where they lie right now.
Yeah, we have a lot to unpack, and we will be talking to some people who are far more comfortable in this world and help us unpack the way that these incentives shape the way that this industry works and also its unwillingness to change. When we come back, we're going to talk to Alden Mitchell, a healthcare industry expert and founder of Carina Health. We'll be right back.
Calling all B2B sales executives. Ready to elevate your sales game? Meet Compose Comp, your partner in sales incentive excellence. Our tailored solutions blend expert design with tech innovation, ensuring your reps have the confidence to close deals. Take the first step to sales success. Visit composecomp.com and schedule your consultation now.
Welcome back to Fuzzy Logic. Our first guest is Alden Mitchell, the founder of Carina Health, a company that's setting out to disrupt healthcare by bringing peer support into traditional healthcare delivery. Welcome, Alden.
Thanks. Happy to be here.
So Chris and I are definitely not healthcare experts at all. Can you help us understand just at large, just the major players in the healthcare space and how money moves between them?
So the three pillars that are most commonly thought of as the agents in healthcare would be the consumer, so us as patient, the provider, which is usually like a hospital system or an independent clinic, the person who's providing the bandage to the patient. And then you'd have the payer, which is the insurance carrier, the government, or an employer, the person who's actually fronting the cash for the cost of the bandage itself.
So it sounds like there's a lot of complexity just in those three pillars, and the fact that call it the customer relationship can be segmented across a few different people, right? Where do you think that complexity has allowed for the industry to obscure some of the power structures that exist and reinforce the status quo that keeps healthcare costs high?
Yeah. If I were to ask how much does your annual primary care visit cost, could you answer the question? It's actually a very real problem. It's not a theoretical problem as much as the economics behind it is complicated theory. So the reason that we don't know how much it costs is in the back office, the hospital systems and the insurance carriers have long had these like lengthy contract negotiations, and they basically continually run these contract cycles to determine how much an insurance carrier will reimburse a provider or a hospital for care. And if you were to take an insurance carrier and look for like the last remaining gem of value the carrier traditionally delivers, it's these contracts with the providers. And it's the secret sauce. It's the Coca-Cola recipe to healthcare. There's no public information disclosed on those contracts. And because those negotiations are really complicated, it's very hard for us to know or predict what an insurance carrier will be reimbursing. And because of that, it becomes nearly impossible for a patient to know in advance what a conditional cost.
Yeah, I feel like we need like a flow chart just to figure it out. But what are some of the ways you think that we can help improve that situation or make insurance companies make that more transparent, given all the effort that goes on behind the scenes?
Yeah, really good question. The complexity here is who's on our side, us being the patients. We need care that makes us healthier, and we need it to not make us go bankrupt. In theory, the insurance carrier is the one helping us lower costs, but the provider is the one making us healthier. So that is the fundamental like flaw here. It's really hard to know who's winning the negotiation. At the highest level, it's like whoever's biggest is winning the negotiation, right? If the insurance carrier has more members and weight in a market than a small provider organization, they're going to have more negotiating leverage on the table, which could mean lower prices to patients. But what we've also seen in a lot of like rural communities is the result of that is providers pull out. Like if they can't make enough money because they don't have enough leverage on the negotiating table, they just opt out. It's hard. We need a large insurance carrier that has the right incentives to lower costs, but we need the providers to be aligned that clinical outcomes are the goal.
Yeah, I think two things. Number one, going back to the Affordable Care Act and talking about the way in which insurance companies are forced to spend their money as a certain percentage of the money that they're bringing in has to be spent on patient care. That means that if you want your profit dollars to go up, the whole pie has to get bigger. Now my incentive's gotten bigger to be bigger. And then from a provider perspective, we're talking about hospital networks. The incentive now is for them to also consolidate and get bigger. And it becomes this arms race on both sides is turning into a very expensive machine that we can't get off or turn off.
Yeah, exactly. In the most simple way, supply and demand is super out of whack. And there's really no way around that. I think the AMAX projects something like 100 to 200,000 physician gap by 2030, which is something like 20%. There's supposed to be something like a 300,000 nurse gap by 2030. The data is crazy, and there's lots of reasons why there's a supply gap, the biggest one being it's super expensive to become a clinician. There's also some cultural systemic bias in our system. So hospitals reimburse fee for service. Like they get money when they administer a service. And anything that's about keeping people healthy is really hard to get reimbursed for. So any preventative care, chronic condition management space has historically been really hard to fund because it's not a surgery. All those different reasons, the supply gap, the just complexities of why or how the providers would get reimbursed and that's impact on the supply really creates this imbalance that ultimately affects costs, agnostic of the insurance provider dynamic.
To that point, tell us a little bit about how Carina fits into that fold.
Carina Health really focuses on patients that are clinically dependent enough, that are needy enough, where traditional like self-service apps don't really work. So this could be high-risk pregnancies, pre-diabetic patients, people living with chronic diseases. This is a segment that is historically not sick enough to receive like one-on-one specialist care or have severe access issues. And so what we're really excited about in this kind of continuum gap, which is hundreds of millions of Americans, we think that a group-based model where a clinician can help support multiple patients with a similar clinical need over a long period of time is a really interesting intervention that's super scalable because the number of clinicians needed to support the patients is way more attractive than in one-on-one care. But there's also this amazing support, peer-to-peer accountability infrastructure that's baked into these groups. So our goal is to help any clinician run an intervention to their patients that is group based. And we make it really easy for them to administer the curriculum, manage the meetings, do the scheduling, all that kind of stuff, while giving the peers an opportunity to collaborate in a secure, moderated environment. And we hope that allows more patients to get better, higher quality care, to have the peer support necessary to really motivate us to change how we live our lives, to live happier, healthier lives, while also making the cost of care way more affordable through this one-to-many model.
Alden, we really appreciate you stopping by. We've learned a lot about healthcare and about how different delivery models can help change that supply and demand equation problem. We're going to take a quick break, and when we come back, we're going to talk with a physician on the front lines of healthcare to talk about her experience and what she's incentivized to do. Stay with us.
Welcome back to Fuzzy Logic. Our second guest is Dr. Leslie Michaud, who founded Motus Biologics and Sports Medicine, a practice that uses cutting-edge scientific advancements to offer minimally invasive procedures in the treatment of orthopedic conditions. Leslie is also my sister, so nepotism is alive and well here at Fuzzy Logic, but happy to have her here this morning. Thanks for joining the podcast, Leslie.
Oh, thanks for the introduction.
You've been in the medical field for a long time, and you've seen both residency, you've worked in practice areas, for-profit, you've worked for surgeons. How has the rising cost of healthcare impacted your work, and where do you think it's impacted it the most?
So I opened my own practice about 7 years ago. And one of the reasons that I did that is I felt like I needed to be able to provide better care to people. Prior to this, I'd been with a lovely multi-specialty orthopedic surgery group, and I acted as their non-operative ortho person within that group. And part of that was seeing 30 patients a day. And there just comes a point where you can't offer as good a healthcare to somebody when you only have 10 minutes to spend with them. And so the model that I changed to was a little bit more of a hybrid model where I could afford to spend more time with patients by seeing obviously less of them, but also I could afford to have my practice because some of my stuff wasn't covered by insurance. And so I certainly still do take insurance, but there's also a component of what I do that doesn't take insurance. And that gives me a little bit more freedom to provide better care to patients.
So in that model, there's the insurance company, there's the provider that provides that care, and then there's the physician. When we think about those things, where do you think the profit mostly lies in the equation? Who gets the lion's share of profit? And who's motivated to drive the most amount of profit?
So, when you talk about rising healthcare costs, you have three big areas. You have just greed, which is everyone's favorite thing to talk about. That's the sexy topic. That's the part that has pharmaceutical companies, insurance companies, executive pay, cost of tests, all of that, physician reimbursement rates. So that's like the greed arena. And then you have the arena which people snooze about, which is the administrative part of medicine. What does it take to make the wheels turn? And no one cares about that, and they don't understand it because it has less of an economic understanding about medicine. And basically what administrative costs are, it's all the people you hire to get the insurance company to pay you, which is a tremendous amount of resources, right? And then the third part of it is the technology. How much does it cost to get these tests? How much does it cost to get access to care? And so you've got three different arenas. And when I opened my own practice, that all came to such a bigger light to where I started understanding the economy of medicine more. And I was able to explain that to patients more. And I'm able to have very transparent conversations that say, listen, I know you love going to this hospital to get your MRI, but they get to charge facility fees. And this MRI is going to be $5,000 as opposed to, listen, there's these three privatized companies that do great MRIs. I love working with them. And it's going to cost you $700 at the most. And so talking to patients about things like that and having the time to do that and understanding that is a big part of why I opened my practice, because I didn't really get the ins and outs of that, seeing 20 or 30 patients a day. Another example of that is saying to a patient, well, wait a minute, you're paying how much for that drug? I do this all the time, and I have nothing to do with their primary care. And they'll tell me how much they're paying for a drug. And I'll be like, let's jump on Mark Cuban's pharmacy or Amazon pharmacy, and let's see about how much that would cost. And sometimes it's 1/10 of the cost. And they just can't believe that no one's told them about this. But the truth of the matter is, you've got an overworked physician population that's employed by these huge hospital systems who can't care about that right now because they've got to get out of this room in 10 minutes and go to the next patient, to the next thing. And they're tired. And learning that and understanding that is a whole other career of medicine.
One of the things that we talked about with our last interview was that at some point, the system gets so big that just maintaining the system becomes really costly. Is that an indication that the healthcare system as we know it today is too big for its own good?
Yes. Short answer, yes. And it tells you how disorganized it is. So there's no standardization to this stuff. Everywhere else in the world, you go and you pay for something and it has a cost and you hand them that money or your card and you pay for that thing. Medicine or healthcare does not work that way. So every single insurance company has different codes, different costs, different negotiation. So I have to charge the same thing across the board for a service, but they don't have to pay me the same thing. And the bigger you are as a hospital system, the more negotiating power and bargaining power you have. And that's called a carve out, right? So you say, well, I take care of all of these people. I don't want to get $86 for a new patient visit. You should give me $120 because I see 40% of your users as an insurance company. And so the administrative cost is really in having these positions that never existed before. So we have billing and coding specialists, claim specialists. We have people who get on the phone all day and get prior authorization and pre-certification to get tests done. And the funny part about that is it still goes through the cracks to where physicians have to do peer-to-peers. So I do probably 3 peer-to-peers a month. And what this is I've ordered a test and I've met all the criteria for that test to be ordered, but the insurance company has denied it. And so I have to spend my time and get on the phone with somebody who has never seen the patient, who might not be in my specialty, who might not even be the same level of education as me, might be somebody who is kind of a tech in some ways. And I have to argue, I got to go to bat for my patient about why they need that test. And sometimes that's a very easy process. And sometimes that's a very frustrating process because that person is reimbursed based on denials. And so they want to argue with me and it can get contentious. And to me, there's nothing I won't do for my patients. And so if I want that test, I'm not utilizing a test that doesn't need to be done. I'm doing it for a reason.
They're incented to scrutinize it to a level where maybe most people give up. And you're incented to try to drive good patient care. And those outcomes are completely different. And the person who gets screwed in the end is the patient.
And so now we're back to the greed component, right? That category, which everybody gets very passionate about. So how do insurance companies make money? They make money by denying things. They make money by passing on copays to patients, by increasing deductibles. It's like car insurance, right? You pay your premium. So the insurance company is getting its premium every month from you. It's like a retainer. And then when you utilize it, they charge you more money. When you have a car, they're not paying for you to put air in your tires and change your oil and maintain your car. They're waiting for you to crash. And that's the system that insurance has built. And so there's this thing, it's funny, I call it copay creep. So one time, Chris, you called me from a doctor's office and you were waiting to see your doctor. And you said to me, "Why are you guys always late?" And I said, "Okay, hang on." I said, "We're not late. Either the patient has come late or copay creep has happened where you had a 15-minute visit as a patient to come in and have your blood pressure checked. That's it. And go over your meds. But you've paid your copay and you're like, now my shoulder hurts, I'm dizzy, and all this kind of stuff." And physicians, because we're generally pretty empathetic people, we want to address those things, but we can't in 10 minutes. And the patient won't make another visit or doesn't want to make another visit because they have to pay another copay. But do you think the insurance company cares anything about that?
No, they probably want a prior authorization for that second visit.
Truly, or any testing, right? Depending on what needs to be done there. If I need to order blood work or things like that. This idea that insurance companies care about you is very problematic. People just need to stop thinking these people care for you. And they need to start understanding how insurance works, right? Because when they get a bill, they're infuriated because they paid a $600 premium for themselves and their spouse for that month. Okay, but that's your premium.
Do you think there's a key to cracking the status quo in healthcare? What do you think needs to change in order for these incentives to align?
The solution to most things are going to be education, prevention, those kind of things. So we need to shift the whole way that we're seeing health in our country. But we're up against a big battle there, right? So if you take the top 3 causes of death in the United States, you've got heart disease, you've got cancer, and you have accidents, right? Number 1, heart disease. There are so many contributing factors to heart disease. And yes, some of those you cannot modify. You cannot modify your age or your underlying gender, right? The genetics of that. And so that's fine, but you can certainly change the way you eat, the way you move, the way you sleep. These are modifiable risk factors that if we put more time and money into prevention, my goodness, we could lower the incidence of heart disease in this country. Even just if we change the way people eat, we lower the level of diabetes, which is a direct risk factor for heart disease. And then you have the second thing, which is cancer. And who has access to the technology for screening tests? Chris, you know about this. There's this amazing blood test that screens for 53 cancers. It's incredible. It's cost almost $900 and it's not covered by insurance. And it's a simple blood test. And further on that is physicians aren't telling their patients about it because they don't want to talk about the cost of it or they just don't know about it. So we have tools to improve healthcare for sure. It's just that we're met with such opposition for getting well.
We're going to take a quick break. And when we come back, we're going to talk about our predictions for the future.
Hey B2B sales pros, want to maximize your team's performance? Discover Compose Comp, your key to optimize sales incentives. We blend expertise and technology to give your reps the edge they need to close deals. Don't settle for ordinary. Visit composecomp.com and unlock your team's full potential today.
Welcome back to Fuzzy Logic. It's time for a special edition of Predictions featuring our last guest, Dr. Leslie Michaud. Chris, Dr. Michaud, thank you for being here. I think we want to wrap up with just some of the things that we've taken away from this episode. My big takeaway was that one of the biggest issues to the healthcare industry and cost today is that the incentive to be big is what's keeping costs inflated, because as all of these insurance companies are trying to negotiate with providers, trying to negotiate back with the insurance companies, there's an incentive to be the elephant in the room. And to maintain those systems, I think Dr. Michaud, you said this really well, it requires a lot of administrative work just because it's really big. And so that ultimately becomes just the foundation of if we keep the system going, then we are going to have to continue to pay these administrative costs just to keep it going. But I'm curious, Chris, what did you see?
So probably the most bizarre incentive structure we'll ever talk about in this podcast, because anything that gets bigger and larger, you expect to pay less for it, right? Just think of our human nature. If I buy more of something at Costco, it costs me less. In insurance, it's the exact opposite. There's a perverse incentive to obfuscate costs. There's a perverse incentive to charge more. And at the end of the day, I didn't get necessarily everything that I wanted. So as the patient, I lose, the physician loses, someone wins. It could be the insurance company, to Leslie's point earlier around there's the greed factor. There's also the administrative factor, that this beast that grows that nobody knows about probably sucks away not only from an insurance company profit, but also from the patient side, the quality of that care.
You've got an industry that spends $3.5 trillion a year, and we don't live any longer than anybody else, and we certainly don't live any better than a lot of countries. That needs to be looked at. But who's going to look at that? Is it going to be the people who, again, are using these perverse incentives to continue their profit margins?
Yeah, we spend more on prescription drugs than we do on highways and Homeland Security combined. Imagine what we would get if we were able to take the money we spend on healthcare and make that more affordable and divert those resources to other things, like preventative care.
And that's the reason why on the 10, you've got a pothole every 50 feet, but that we've suddenly been able to create not one, not two, but 3 different types of weight loss medications that can make you the skinniest person at the beach club this summer.
That's right. For the cost of a 1-bedroom apartment in Kansas City, you can have that drug every month.
Seriously, it costs that much? That's the difference.
Usually if people pay out of pocket for something like Ozempic, they're paying anywhere from $650 to about a little over $1,000, depending on where they're getting it from.
Matt brought up Costco. That Costco has it now. I don't know if Kirkland brand Wegovy is the way I would go, but
Kirkland has never failed me with golf balls, vodka, or steak. I can't imagine they're going to fail me with prescription drugs either.
Okay, but here's this is, we're making a joke, but this is a really good example, right? If you wanted to try to go through insurance to get that drug, you certainly should meet criteria. I'm not saying you should just have access to it. Ultimately, we're going to be able to prevent heart disease with that drug because people are not going to be diabetic. They are going to be not meeting the metabolic criteria anymore. So they're, you'll start to see that their cholesterol will normalize if they're obese. But again, the incentive to be healthy isn't there. It's more to be skinny, right? To be thin. And so I guess reshaping your view of wellness and health, but also reshaping how is this juggernaut running right now? We didn't even touch on the executive salaries of these administrators for these hospital systems. This is my concern. Everybody talks about regulation. Well, we need to regulate all these things, but we have to think about what that's going to do for a for-profit system. What they'll do is they will rob Peter to pay Paul. So they might not do as much R&D, or they might not contribute to preventative care as much, so that they can make up for maybe some salaries that were lost.
Has everyone just, in your opinion, just adopted the system because it's been in place for so long that it runs the way it does? No one necessarily knows, how do we unwind all of this mess that we've created for 50 years?
Listen, I don't even think the average consumer understands it because it's such a confusing system, right? It's like the emperor's new clothes. Everybody's just like, great, it's healthcare. And it's like it's walking around naked, right? And no one's saying anything about it. Like something's wrong here in the room, but let's just all go along with it.
Fast forward to 10 years. What's our prediction for the healthcare industry? Knowing what we've talked about with the incentive structures today, what's got to change before it gets better?
It's going to be the same in 10 years, guys. I hate to say it. It's going to be the same in 10 years. Change in this industry takes so long. It's like you're trying to turn around the Titanic. And so if you ask me what it might look like in 30 years, I would tell you, I think we're getting to a point where people understand and they're revolting and they're saying they're not trying to help me and I'm paying a lot of money. So I think what you're going to see is a lot of what are called meta-share programs where people say, I'm not going to go through a insurance company anymore. And I'm seeing more of this every day. Groups of people where they're their own board and everybody puts money in a pile. And when you need to use it, you get that money and that little board gets to allocate that money. But But again, going back to it, once it gets too big, it will collapse.
I think the seismic shift will happen when Medicare goes bankrupt, and it's going to happen. Like, there's just no way around it. Everyone wants to bury their head in the sand. I don't care what part of the aisle you sit on. Social Security and Medicare are going to go broke. And Medicare, once it goes broke, people, especially older people, are going to say, WTF did you people do? And I think that's going to create a shift that says, all right, we're going to start holding people accountable, but it's got to be something to that order of magnitude, I think, to change the status quo.
Unfortunately, this episode has taught us that it's probably going to get worse before it gets better, because right now there's enough entrenched interests and there's enough of them that, the system's kind of lumbering along. It's really big and complicated, but it's still hard for people to pinpoint, here's where the problem is, here who the problem is. As we start to see more consolidation in the healthcare provider space and the network space and the insurance carrier space, it'll just start to be easier to point fingers at who the problem will become, and that will ultimately create some kind of a need for us to change our healthcare system. But until then, it's buckle up, hold on for dear life, and hope you don't get sick.
On that positive outlook for this week, thanks so much, everyone, for tuning into this week's episode of Fuzzy Logic. Fuzzy Logic is produced by Mitch Rissmiller. New episodes drop Wednesdays wherever you get your podcasts. We'll see you next week.